Hi, my name is Andrew Gonawella. Welcome to the Burn Bag Podcast. I'm delighted to have a very special guest join me here today. Dr. Anthony Fauci is joining me here today. He's probably the biggest guest I've ever had on this podcast. Ironic, this is a foreign policy podcast, and I have a doctor joining me. So, Dr. Fauci, thanks for joining me here today. I really appreciate it.
My pleasure. It's good to be with you.
So for our audience, many of you know Dr. Fauci in the context of COVID, but he's had a decades-long career in public health. Dr. Fauci is an American immunologist who has served as the director of the National Institute of Allergy and Infectious Diseases, otherwise known as the NIAID, from 1984 to 2022, playing a key role in the U.S. response to HIV and AIDS, Ebola, COVID-19, and many other public health crises affecting our nation. Dr. Fauci currently serves as a distinguished university professor in the Georgetown School of Medicine's Department of Medicine in the Division of Infectious Diseases, and he is the author of On Call, his fantastic autobiography, which is superbly candid and really gives you an insight into his career, his life, but also public health crises throughout the decades through the lens of his career. While, of course, so many of us know Dr. Fauci in the context of COVID-19, this conversation will primarily serve as a discussion around Dr. Fauci's career trajectory and his experiences in addressing many of those public health crises I alluded to before. So, Dr. Fauci, thank you again. On a personal note, I was the class of 2019 at the University of Michigan. A lot of my friends were in the class of 2020. You spoke to them in 2022 at the comeback commencement, where you received an honorary degree from the University of Michigan. In my mind, that makes you a University of Michigan alum and also a fellow Wolverine. So from one Wolverine to another, go blue.
Go blue is right.
And I'm sorry, I know Michigan State University in 2023 also gave you an honorary degree. No harm on them, but hopefully since we were first, when Michigan plays Michigan State, you're saying go blue and not go green.
Something to even rub you the wrong way again, Andre, is that I also gave the commencement address at Ohio State.
Oh, no. Oh, that is absurd.
I'm sorry. Forgive me.
Well, hopefully you were cheering for Michigan when we beat Ohio State the last few years.
I was. I have a lot of members of my laboratory at the NIH when I was there who are Michigan alums, not only of the undergrad, but also of the medical school. So
fantastic.
I have that indirect connection to Michigan.
Awesome. So, Dr. Fauci, as we're starting this interview, it's a very challenging time, a time of uncertainty for those in public service. I'd like to start by asking you, why did you choose to spend your career in government, and what does public service mean to you?
Well, public service has been, ingrained in me from the time I actually, without fully realizing it, from the time I was a child. My parents, my father, now back in the 40s and the 50s, 1940s and 50s, ran a small mom and pop type shop of a pharmacy. He was a pharmacist in New York City and Brooklyn. And at that time, the pharmacy served as the hub of the community service. You were the neighborhood psychiatrist, marriage counselor, physician, surrogate for some. And his main purpose was to serve the community. And the community then was a neighborhood in the Bensonhurst section of Brooklyn. So from the time I was a child, this idea about the importance of serving others was embedded in me, even without my full conscious realization of it. That was fortified as I went on my educational journey. One with the Catholic school nuns at Our Lady of Guadalupe in Brooklyn, and then importantly, my high school experience with the Jesuit priests at Regis High School in New York City, and then at Holy Cross College in Worcester, Massachusetts, where the theme of the college and what is the theme of the Jesuit order is service for others. So it was almost a natural evolution of my career trajectory from the time I was a child through my education to want to do something that was fundamentally aimed at helping people and serving the community. For me, that turned into a career in medicine, in the sciences and in medicine, but also to do it in the context of having a broad, hopefully positive impact on broader groups of people. And that's the reason why I spent essentially my entire career in the United States government at the National Institutes of Health.
Absolutely. And you're on the faculty of Georgetown University today. For our audience, Dr. Fauci's background says Georgetown University quite repeatedly, and that is interestingly a full circle moment for you, given Georgetown's history of Jesuit education. So I think that's very interesting. So, I mean, sort of follow up, why back to Georgetown? Did that Jesuit education, that approach appeal to you at Georgetown in any way?
Yeah, there were a couple of things. One of them is what you mentioned. But when I had been at the NIH from the time I finished my medical residency training of several years in internal medicine residency, I came down there for a fellowship, went back to New York for a year as chief medical resident at the New York Hospital. And then I have spent my entire professional career at the National Institutes of Health, doing research, both basic and clinical research, and getting involved, as you mentioned, particularly when AIDS came along, in public policy, public health, and global health. So I decided after 54 years at the NIH, 38 of which I served as the director of the National Institute of Allergy and Infectious Diseases, that after all of that, I wanted to spend whatever remaining years I have in serving as hopefully an example and an inspiration for younger people who might be interested in public health or public service. And I decided that for me, the best way to do that would be to get involved in a university setting, which not only had a medical school and a school of public policy, and I do have a joint appointment both in the medical school and in the McCourt School of Public Policy, but the atmosphere where I'm at is right in the middle of the Georgetown campus. So you have the undergraduate arts and sciences, you have the School of Nursing, the School of Health. Downtown, you have the law school, you have the School of Foreign Service. So it is really an extraordinary opportunity to interact with a significant number of young, bright minds that I might hopefully have a positive impact on. So that's what I've done since the time I stepped down from the NIH at the end of 2022, the beginning of 2023. And I've been doing it ever since. And it's really been extremely gratifying. So it was a very good choice, I believe, on my part to do that.
Yeah, one would assume that given your lengthy experience, your lengthy career, you just want to retire after all you've been through. So, I mean, it's very admirable that you are still working at this time. My manager wanted me to ask you how you keep your running regimen, really going as well. So maybe we'll chat
Well,
a bit offline about that.
oh, you could tell your manager that I don't run now because when I bounce and the impact,
Ah,
it hurts my back. But I walk about 4 miles a day, and I
geez.
do it every morning. I get up and before I do anything else, I just go out and do a power walk for about 4 miles, and then I'm set for the rest of the day.
Well, you're making my 27-year-old self feel very ashamed of myself right
I'm
now.
sorry. I'm sorry.
Well, so going back to the beginning of your career, why infectious diseases? You spent some time at Cornell's medical school. Why did you want to pursue infectious diseases as your specialization?
Well, that's a good question, and I try to analyze that because I get asked it a lot. My kind of personality, the thing that resonates best with my frame of mind is I like to address problems that you can identify that aren't vague. One, that you can prevent the problem, and when the problem occurs, you can treat it, and that it is serious enough that in and of itself, it can really cause a great deal of suffering and if
Mhm.
not death. And that's exactly what infectious disease does. It's caused by a definable agent, be that HIV or malaria or tuberculosis or what have you, For the most part, in the right circumstances, you can prevent the infection. When the infection occurs, we often have effective therapies. We have vaccines to prevent some of the life-threatening diseases, and you can treat it. And it's a formidable foe because many infections that we know, if you go back and look at the causes of death, 24% of all the deaths in the world are
Hmm.
from infectious diseases. And that's down from decades ago before we had really good antivirals and antibiotics and vaccines, that it was even more than that years ago. So it's a serious disease. It's preventable and treatable. And that's what I liked. I wanted to be able to definitively do something about a disease that I was addressing my training against.
No, absolutely. So obviously, when I told all of my friends and my family that I'd be talking to Dr. Fauci on the burn bag, many of them obviously wanted me to ask you about COVID. However, a lot of my friends in medicine, my friends in public health, wanted to know more about your time dealing with the HIV and AIDS situation. And how did that come to define your early career? Because that really was what defined your career. You received the President's Medal of Freedom from President George W. Bush for your work on HIV and AIDS, which many in the general public may not know about.
Yeah, you're absolutely correct. Most people, because of the great broader impact that COVID had, know me only with regard to COVID. But I have spent 44 years of my life directed at HIV/AIDS, and my involvement in HIV goes back to the very, very first recognition of cases in the United States in 1981. And it was a very interesting pivoting in my career. And let me explain what I mean by that. When I finished my formal medical training in internal medicine, when I was chief medical resident at the New York Hospital, which is now Weill Cornell in New
Mhm.
York City, um, I came down to the NIH and spent the next 9 years developing some effective therapies for autoinflammatory or autoimmune diseases. And I had a very successful career trajectory, and I was doing very, very well. In 1981, when I heard about, in the summer of 81, the first cases which turned out to ultimately be AIDS, it was very interesting. I read a report from the CDC in June of 1981 of five, curiously all young, otherwise previously healthy gay men who developed a strange sort of pneumonia that you only see in people who are immune compromised. I thought it was a fluke and kind of an aberrancy that didn't mean much. And then a month later, in July of 1981, I saw the second report from the CDC, now 26, curiously and
Hmm.
strangely, all otherwise previously healthy young gay men who not only developed this deadly kind of pneumonia, but also other types of opportunistic infections and a strange cancer called Kaposi's sarcoma. And I made, now retrospectively thinking about it, a monumental decision of my career trajectory. I decided to put aside what I had been doing successfully for the previous 9 or 10 years and devote my entire effort to studying, taking care of, and doing research on this brand new, devastating, mysterious disease called HIV. And I started that in the fall and winter of 1981. And I was heavily involved in that for the next 40 plus years until I stepped down as director a year and a half ago.
Yeah, and I mean, HIV and AIDS really came to define so much of your career, not just your early career, but your full career. Can you tell us a little bit more about the National Institute of Allergy and Infectious Diseases? I mentioned it earlier in the introduction. You were the director of it. What does it actually do, and what were your initial days at the helm of that institute like in the midst of the HIV/AIDS crisis?
Yeah, well, I the National Institute of Allergy and Infectious Diseases, when I took over, was a relatively small institute. Among the NIH Institute, it was about the sixth or seventh largest. It is responsible for the study of all infectious diseases, both those that are here in the United States, as well as globally important diseases like malaria and other types of
Hmm.
global health challenges that go well beyond the borders of the United States. Also, we do a lot of research and fund research on immunological mediated diseases and understanding the intricacies of the human immune system. Uh, we do research that we have government scientists like myself who actually conduct the research, but the most of the resources of the institute goes out to the funding with grants and contracts of scientists throughout the country, mostly at major university medical centers, Harvard, Yale, Cornell, Wash U, and places like that. Um, so I took over the institute when it was relatively small, and I was the director for 38 years. Since we were the Infectious Disease Institute, when this brand new mysterious disease came along, it was our natural responsibility to be the lead agency in doing the research, in understanding the disease, in discovering the cause of the disease, and then importantly, which is one of the most important things that I've been involved with in my career, was working at the basic science level in collaboration with the pharmaceutical companies to develop the life-saving antiretroviral drugs that turned HIV/AIDS from an almost certain death sentence into an entirely manageable disease. And one of the important landmarks in my experience in my
Hmm.
career is in the beginning in 1981, 2, 3, 4, 5, 6, when besides doing research, I was personally, physically taking care of large numbers of desperately ill, mostly gay men, not always, but mostly gay men
Yeah.
had, who had HIV/AIDS. And it was the dark period of my professional career because we did not develop effective drugs for several years into the outbreak. So we went for a number of years where most of the patients that we were taking care of were dying within 12, 15 months to 2 years from the time they presented with their disease. And that's the reason why I made another change in my career in 1984, even though I really did not want to get involved in the administrative aspects of science.
Hmm.
The job of the director of the National Institute of Allergy and Infectious Diseases opened up. The person who was currently the director went off and became the dean at a medical school. And I was asked to take that job. And the reason I took it is because I felt at the time that we were not paying sufficient attention to infectious diseases in general, and specifically, we weren't putting enough attention on this emerging pandemic of HIV. So the HIV epidemic was one of the major motivating forces of my accepting the job as the director of NIAID, where I would have not only scientific input, but some policy input and some input into the kinds of resources that would go into HIV. So that was the defining period of my career when I made that pivot into AIDS research. And then a couple of years later, I assumed the job as director of the Institute.
So, for those of us who aren't as aware of the science behind medicine, the science behind these life-saving drugs, how did those life-saving drugs come to be? How were those evolved? How did, I mean, in 81, you identified that problem. You were treating so many of these folks who were suffering with this disease, especially as they were dying by large numbers. So, how did you, I guess, identify the processes
Sure.
and the efficiency behind the drug development, basically, for the
Well,
lack of a
it was,
better
yeah,
question?
no, I know exactly what you're saying. It was a step by step process. First of all, you have to identify what the causative agent of the disease is. And we did not know that until 1983, 84, because in 1981, 82, and early 83, we had not yet identified the virus, in this case, which we named the human immunodeficiency virus, or HIV. Once you identify the causal agent, you could then start trying to develop various compounds, chemicals, namely drugs, that could suppress the virus first in a test tube and then ultimately in a clinical trial. And little by little, over the years, starting with 1986, when the first drug, which wasn't even developed specifically for HIV, it was a drug that had been formally developed for cancer, but wasn't a particularly effective drug for cancer. It was called AZT.
Hmm.
But we found out, interestingly, that it dramatically blocked the replication of HIV. So the next thought and practical move would be to use that drug in a clinical trial to see if it can suppress the virus in the person. And we did, and it was a dramatic result that people who received AZT over a period of time did much better, temporarily at least, than people who did not receive the drug. That was the first huge success. And then from 1986 till 1996, we gradually developed more drugs in association with and in collaboration with the pharmaceutical companies because they were interested in developing these drugs. And we would go into a clinical trial and test them to see if they actually suppress the virus. The watershed year was 1996, when we finally had a triple combination of drugs, which when given together, because one drug worked for a while, but then lost its efficacy. Two drugs, the same thing. When we finally got three drugs that targeted different vulnerable parts of the replication cycle of the virus, then it was off to the races. Then from 1996 to the present time, we perfected the drugs. They got better and better. And now, today, if someone comes into my office or my clinic recently infected with HIV, and I put them on a drug, which now you can get three drugs in one pill and
Wow.
take it a day, you can actually tell that person that if they take that drug regularly, that they will live essentially a normal lifespan. That is one of the greatest achievements in biomedical history, because if you go back and look at what I was doing in 1981, 82, 83, when no matter what I did, every one of my patients, with few exceptions, would die. Fast forward to today, that if you get someone early enough in their disease and put them on an antiretroviral drug regimen, you can tell them they could essentially live a normal lifespan, maybe with a year or two less than the average.
So in that context, is that sort of what, because when we think of famous folks who have HIV, I think a lot of folks will think of Magic Johnson, for example. He's been doing pretty well. So would you say that's similar to sort of his situation?
Exactly. No, I mean, I know Magic. I consulted with him about his disease. No, he was fortunate in that he got infected at a time when we had the drugs that were highly effective in suppressing the virus. So he had very good control of his virus. And if you look at him now, he's the picture of health. I mean, he
Yeah.
looks terrific. But if you look at people that I and my colleagues were taking care of in the early 1980s and in the mid to late 80s, before we had effective therapy, it was a different story. Most of those people did not do very well.
So when we talk about HIV and AIDS, a lot of folks in a political context will think of the Reagan administration, will have critiques of how the Reagan administration handled that. But you talk about one president in particular in your book. You dedicate a whole chapter to him, President George H.W. Bush. And I was very curious about why you dedicated an entire chapter to President Bush. Now, I admire President Bush for many reasons, particularly his dedication to public service. But how did your friendship with President Bush impact your work on AIDS?
Well, when President, you alluded to it a moment ago that uh, with all the positive qualities that President Reagan had, he did not properly use the bully pulpit of the presidency to call attention to this emerging outbreak of HIV. And in fact, unfortunately, he did not even mention the word AIDS until the second year of his second term, which really, people
Yeah.
were very disturbed by his not utilizing the presidency to essentially call attention to this. When George H.W. Bush, who was vice president at the time, decided he was going to run for president, he made a decision he needed to learn a lot more about HIV. So he came to the NIH and I showed him around, and we developed a very important friendship for me that we got to know each other very well. And I interacted with him a fair amount towards the last year or so of his vice presidency. And when he became president, he then called upon me to help him to figure out what we needed to do for HIV/AIDS. And the resources dramatically increased, of course, with the help of the bipartisan support of the Congress. So he was the first one who really understood that we needed to do a lot more for this, even though the activists, I think, appropriately criticized him for not
Hmm.
necessarily doing enough. But I developed a very, very strong relationship with him, which continued after he stepped down from the presidency. We would be contacting me and writing me notes and checking on how I was doing. The other important thing is that that's when I met his son, who George W. Bush, uh, during the George H.W. Bush presidency, was a staffer in the White House. That was before George W. Bush was the governor of Texas and before he was the owner of the Texas Rangers. And then, as we'll get to in a bit, my
Yeah.
relationship with George W. Bush played a very important role in the history of HIV.
So before we talk about your relationship with George W. Bush, just one more thing about President Bush 41. In your book, you talk about a time where you said no to President Bush. Can you tell us a little bit more about saying no to the President of the United States?
Yeah, well, um, as I got to know him better, when he became the president, um, he had to pick the NIH director, which is a presidential appointee. Um, and he wanted me to become the director of NIH. I was director of the National Institute of Allergy and Infectious Diseases, which is one of several institutes of the NIH. I did not want to be the director of NIH because I wanted to stick with my core competency, which was in infectious diseases and immunology, and I wanted to devote much of my time to addressing and fighting, as it were, the HIV/AIDS epidemic. But he still wanted me to be the director because he liked me and he was confident in my capabilities. So he had asked uh, Secretary of HHS Lewis Sullivan
Hmm.
that I want Dr. Fauci to be my NIH director, go offer him the job. And uh, Lou said, do you want to be the NIH director? And I says, Lou, I'm really sorry, but I don't want to. And I thought that was the end of it. And then about a month later, I get a call from Lou Sullivan saying the president just called me up again and says, what's going on here? I thought we were getting Tony Fauci to be the head of NIH. So Lou, wonderful guy that he is, he called me up, brought me down to his office at HHS and said, listen, the president wants you to be the director of NIH. If anybody's going to say no to him, you are. So you come with me to the White House and you tell him no. So we got into his car. We drove down to the White House, went into the Oval Office, and I was let in. John Sununu was the chief
Hmm.
of staff at the time. And we walked in, and I still was convinced I was going to say no. But George H.W. Bush sat me down by the Resolute desk and said, I really would like very much for you to be the NIH director. And I looked him in the eye and I said, Mr. President, I'm very sorry. I believe I can serve you and the country better if I stay in my current position as the director of NIAID. And I hope that this doesn't offend you, but I really do believe I can do a better job here. And he just looked at me, for about 10 seconds. It seemed like 10 minutes. And he looked at me and he said something that was wonderful, which is the reason why I have such a great deal of affection for him. He said, Dr. Fauci, I respected you a lot before now, but I respect you even more. So go ahead, do your thing, get a hold of this HIV epidemic, and do what you feel is important for the country. And our friendship even strengthened after that, which, you would have thought that maybe he would have been a little bit annoyed that I turned him down. And it was very interesting because, you don't say no to the president of the United States. As we were walking out of the Oval Office, John Sununu, who is a really good guy, put his arm around me and with a smile on his face said, "You son of a bitch, nobody says no to the president." But it was all in good fun because he realized that the president was not offended when I said no.
Absolutely. So now moving on to your work with his son, President George W. Bush. Many folks will often criticize President Bush for his foreign policy, national security, and so on. But one of his greatest legacies that I think is undisputed is PEPFAR. You were one of the architects of PEPFAR. What is PEPFAR and why was it so unique?
Well, PEPFAR stands for the President's Emergency Plan for AIDS Release, PEPFAR. Getting back to what we discussed a moment ago, that when we got to 1996, that triple combination of drugs was dramatically life-saving for persons with HIV. And from 96 to around 2001, as the drugs got better and better, it was almost miraculous how good these drugs were. That was the good news. The sobering news is that these drugs were available for countries like the United States and Canada and Australia and some of the European Union countries that were rich enough to be able to afford it. However, 67% of all the infections were in sub-Saharan Africa, and 90% of the infections were in low and middle income countries. So it was a painful experience and realization that the people who needed the drugs the most, namely in Southern Africa, were still dying from HIV in the year 2000, 2001, whereas people who had access to drugs were doing very well. That disturbed me greatly because I have a strong sense of, empathy for suffering people, but also for the need of equity in the availability of life-saving interventions. So I was pushing to try and figure out what we can do to get drugs to people in the developing world. Fortunately for me and the world, George W. Bush felt the same way. And he called me into his office in 2002 and said, with these almost exact words, he said, I feel we have a moral obligation as a rich country to not allow people to suffer and die from a preventable and treatable disease merely because of where they happen to have been born. So he sent me I had been already to Africa multiple times because that was the epicenter of HIV. He says, go back to Africa and figure out, can we do something that's transformative and accountable to really turn around the situation with HIV in Africa. And I did. I went there, I met with my African colleagues who were in a position similar to the position I was in the 80s when we didn't have any drugs. Now we had drugs, but they were not available to them. And I came to the conclusion that we could put together a program that would be accountable and would be transformative. And I went back to the White House and I presented it to President Bush. And I told him that it would really take a lot of money to do this. And in his typical way, he said, let me worry about the money, just put the program together. So I spent the next several months from like May or June of 2002 until the end of the year working with the White House staff and some of my own colleagues to put together what turned out to be the architecture of the president's emergency plan, which was originally scheduled to invest $15 billion over 5 years to treat 2 million people, to prevent 7 million infections, and to care for 10 million people, including AIDS orphans. So I presented it to the president. He accepted it. He announced it at the State of the Union address on January 28th of 2003. And 20 years later, in 2023, we had a meeting, a semi-celebration in Washington, D.C., where George Bush came with his wife, Laura, and the team that put together the program with me. And we looked at the data, and that program, 20 years later, had saved 25 million lives in the developing world. So you're absolutely right. I mean, he will go down in history of global health as being the person that allowed for a program that had one of the most important positive impacts on global health in all of history.
Yeah, and I think with that aspect of his legacy, like that can't be disputed at all. I mean, that is an extraordinary investment of US taxpayer dollars to save tens of millions of lives, particularly. And I appreciate you outlining his moral obligation, or that he outlined to you, that you write well in the book. It's really incredible. And when you're talking about PEPFAR, you're sort of alluding to this model that you put together, that you architected. Can we apply that PEPFAR approach to other public health challenges?
The answer is yes. And towards the end of his presidency, we were trying to figure out, can we apply that to tuberculosis and to malaria? Because if you look at the three major global health killers, it's HIV, AIDS, tuberculosis, and malaria. And all you need is leadership and resources and the commitment of resources, and you could actually do that. So the simple answer to your question is that you can provide a PEPFAR model for other diseases. And I would hope that we do that. We haven't done that since, but I would hope we do.
Absolutely. And folks, again, many of you listeners know the Burn Bag as a national security and foreign policy podcast, but part of national security, in my view, is health security and really human security. And a lot of what me and Dr. Fauci are talking about today is about health security and human security. So this is very national security for our audience. But something that may be a little bit more traditional national security is you're dealing with the anthrax crisis in the early 2000s, which really demonstrated the risks around biosecurity and weaponized bacteria or viruses. How did that anthrax scare and the broader war on terror change your views on the risks of bioweaponry and bioterrorism?
Well, actually, the risk of bioterrorism was always there. I mean, it goes way back to the Cold War, where the Soviet Union had stores of botulism and smallpox and tularemia that, just in case they wanted to do bioterror in a bio warfare. So that's not anything new. The thing about anthrax that I think indirectly had a positive effect on our preparation for natural disasters is that when the anthrax attacks came in the fall of 2001, the president asked me to put together a program he gave us about $1.5 billion to prepare countermeasures against potential agents of bioterror. And there was a list of them that we knew the Soviet Union had been stockpiling: smallpox, botulism, those kinds of things. But what I was able to successfully convinced President Bush to allow us to do was to use the same sort of preparedness, not just for a bioterror attack that was a deliberate attack by a state enemy, but to use the resources to prepare us for the natural occurrence of outbreaks that weren't deliberate at all. They just naturally occurred. Because if you look at the history of global health, the worst bioterrorist is nature itself. When you look at the bubonic plague of the 14th century, the influenza pandemic of 1918, all of those things are naturally occurring. So what we did is that we put together a program that would be able to prepare for and respond not only to the unlikely occurrence of a deliberate attack, but the more likely occurrence of a naturally evolving outbreak, like we've seen with COVID, like we've seen with influenza, like we've seen with Ebola, like we've seen with Zika.
Yeah, absolutely. And I mean, when you talk about all of those diseases that you just mentioned, Ebola, Zika, COVID, but well, leaving aside COVID, but really Zika, Ebola, swine flu, H1N1, what trends did you notice in the 2000s and 2010s with these infectious diseases? Because I feel like I'd hear about one of these every few years. Now we're hearing about it with the bird flu, particularly. A lot of people are scared about that. What trends are you noticing? And I guess what words of advice would you have for folks who are concerned about the bird flu, for example?
Well, yeah, let's take the bird flu. One of the reasons of the great concern about the bird flu, the H5N1 bird flu, which kills mostly chickens, but also waterfowl and others, that was recognized in 1959. It wasn't until 1997 in Hong Kong where it first jumped species, not only killing chickens, but jumped from a chicken to a human. And it was very deadly, 30 to 50% mortality.
Gee.
The issue is that it did not spread from human to human. So right now, the H5N1, because you fast forward, the first time it was noticed was 1997. Then there was a big splurge in 2000, 2003, and then again a few years later. So now in 2024, 2025, we have H5N1. The reason there is more concern about it is that it has now gone into mammals. Chickens are not mammals. Cows are mammals, as are cats and pigs. So once it gets into a species that's closer evolutionarily to a human, it gives it a greater opportunity to evolve itself to spread from human to human. And right now, according to the CDC, the risk is still low, but you have to really keep an eye out on what's going on. There have been 68 cases of H5N1 bird flu that have infected humans. One case of someone dying, 2 cases of people with serious disease. So it's still at that stage where it's not threatening in the sense of evolving to spread from human to human. But, a few mutations could change that. And then you could have a virus like H5N1 that does spread efficiently from human to human.
Well, that's terrifying. Really, really, absolutely terrifying. I think everyone's still recovering from a couple of years ago, but now going into what happened a couple of years ago, given these other infectious diseases, H1N1, Ebola, Zika, now we're dealing with the bird flu, was the COVID-19 pandemic inevitable in your view, or was there something more exceptional about it?
Well, I'm not sure what you mean by inevitable, but the way I frame it is that there have been pandemics since before recorded history.
Hmm.
Recorded history, direct and indirect, shows that there were devastating outbreaks. I mean, the bubonic plague of the 14th century killed 1/3 of Europe. The
Yeah.
pandemic flu of 1918 killed 50 to 100 million people in a world's population that is 1/3 the size of the current population. So you could imagine if you do the math
Huge.
and see how many people would have died, it was just thoroughly frightening. Pandemics will always occur. Um, I wouldn't say COVID was inevitable, but some pandemic is inevitable to occur again. And the question is, what can you do to prepare for and respond to these outbreaks? Most of the outbreaks, 75 to 80% of new outbreaks, are zoonotic. By zoonotic means they fundamentally are an animal reservoir virus or pathogen that jumps species and adapts itself to human. And then most of the time it's a one-off and doesn't go anywhere. But if it adapts itself well to humans, then you can have spread. That's what we have with influenza. That's what we had with COVID. And that's what we hope we don't have with H5N1.
So, how did you view COVID-19 at the pandemic's outset, and how did that perception of COVID-19 change as the pandemic wore on?
Well, it was, one of the things that I write about and speak about when I talk about lessons learned from our experience with these outbreaks is expect the unexpected, is what I say. That's my first lesson. And what I mean by expecting the unexpected is that what we learned from COVID, that it was a moving target. We had not experienced anything like it before. And as the knowledge of what was happening evolved, we were in the position of having to explain to the American public that first we thought from the information from China that it didn't spread particularly efficiently from human to human. Then a week or two later, we found out, wait a minute, it's spreading very efficiently from
Yeah.
human to human. And then the original paradigm of respiratory infections was that people spread a respiratory infection when they have symptoms, when they're sneezing or when they're coughing. We learned after a while, much to our dismay, that that wasn't the case with COVID, that 50 to 60% of all the transmissions with COVID was from someone who had no symptoms at all, which makes it very difficult to do identification, isolation, and contact tracing. It makes you have a different perspective on wearing a mask or not, a different perspective about social distancing. So it was a learning process that as the months went by, we learned things that we didn't learn or know in the previous month. One of the things that was a real surprise was the enormous number of variants that evolved over the 4 to 5 years that we've now had experience with COVID. When you have a flu outbreak, even a very severe one, in any given season, the virus essentially stays the same. From
Yep.
season to season, it drifts a bit. But within a given season, it generally, not always, but generally stays the same. What we've experienced with COVID, first with the original strain, and then alpha, and then beta, and then delta, and then omicron. And right now, if you look at the phylogenetic tree or, the evolution of the virus, we're now in multiple variants down the pike that were very different than what we had originally. So it taught us a lot of lessons. And that's why I put it under the broader category of expect the unexpected when you're dealing with an outbreak.
Yeah, no, absolutely. And I think that's what was so terrifying about it. I mean, such a new experience. I mean, a new experience for everyone around the world. But Dr. Fauci, you were, of course, very affiliated with the COVID response. So many people in my generation, everyone, I mean, came to know you as sort of the person most identifiable with this, particularly on your advocacy for the vaccine, for the boosters. I mean, when me and my friends got our jabs, our boosters, we often call them an endearable jest, our Fauci ouchies, basically. So I don't know if anyone ever gave you a pin with that sort of slogan or how you feel about that.
Yes, indeed, they did.
Yeah, but I mean, not many know about sort of your work on the vaccine or sort of how that went about, particularly the Vaccine Research Center's work under the NIAID. How did the Vaccine Research Center contribute to the development of the COVID-19 vaccine?
Yeah, we put together during the Clinton administration the Vaccine Research Center on the NIH campus that I reported directly to me. And their mandate was to first originally develop a vaccine for HIV. So I brought together scientists from all over the country, young, brilliant scientists, to work together on developing an HIV vaccine. And they developed a number of sophisticated technologies to develop immunogens, or what we call the business end of a vaccine, and put it in the right conformation to get the optimal response. However, they were so good at what they did that they were called upon to develop vaccines for other pathogens like respiratory syncytial virus and Ebola and influenza, the universal flu vaccine work that has gone on. Now, having said that, when COVID came along, the work that they had been doing on developing the proper immunogen and conformation for an HIV vaccine
Hmm.
allowed them to make a discovery on what the optimal antigen, not antigen, but immunogen for a COVID vaccine was. And together with the new mRNA platform, that immunogen is the immunogen that's been used, and an immunogen is just that component, the important component of the vaccine, that they were responsible for developing that part of the vaccine that was successfully used in virtually all the COVID vaccines. So my main, even though I was known because I was on TV a lot trying to tell the American people what they can do to keep safe, my day job was to run an institute
Yeah.
that was developing, in collaboration with the pharmaceutical company, the vaccine that ultimately now, when you go back and you look, has literally saved, 10, 15 million lives worldwide, maybe more, maybe even 20 million lives worldwide.
So when you're talking about the vaccines, we've had this vaccine skepticism that's pervaded American culture and global culture really for the past several decades. And it really went out of proportion, I think, with the COVID situation. How do we combat vaccine skepticism? What do you think are the most effective strategies for really improving vaccine education and trust, particularly in communities where misinformation has led to lower vaccination rates?
Well, under normal conditions, you could have a plan about how you counter that, but the amplification of misinformation and disinformation on social media makes it very, very difficult to do
Yeah.
that. But we should not give up. We have got to continue to provide evidence-based information to the public in a way that they can understand and accept. Don't talk down to them, and don't get too complicated about it, and just appeal to the reason and the rationale of the people to understand the facts of the data are very, very clear. If you look at the hospitalizations and deaths among people who were unvaccinated compared to the hospitalization and death of vaccinated people, it is striking the advantage of the vaccines in saving lives and preventing hospitalizations. We've got to stick with the data and the evidence and present it in a non-confrontative way, but in a user-friendly way, as it were,
Hmm.
to the general public for them to understand. And we have to try as best we can, and it's not easy, to counter the egregious misinformation and disinformation that sometimes gets out there and is, as I mentioned, amplified greatly by social media.
What are some of your biggest fears and concerns related to public health in the United States today, particularly when it comes to public health threats that we're not really talking about, in the mainstream discourse?
Well, My discipline and my lane is infectious diseases. So I am always primary on my own mind, concerned about the evolution of yet again another pandemic. I mean, people used to ask me 10, 15, 20, 25 years ago, Dr. Fauci, what is your worst nightmare? And I'm on the record, you could go back
Yeah.
and check it, of saying my worst nightmare, my fear is the evolution of a brand new virus that likely comes from an animal species, jump species from an animal reservoir, that's respiratory borne, that easily transmits from person to person, and that has a high degree of morbidity and mortality. And unfortunately, that's exactly what happened with COVID. And my worst nightmare, unfortunately, came true. My persistent nightmare is yet again another respiratory borne infection that will have an impact. That could be flu, that could be bird flu.
Oh, gee.
Problems that I'm concerned about that are not necessarily infectious diseases. I mean, we have a serious epidemic of obesity in this country
Hmm.
that leads to diabetes, heart disease, hypertension, and a variety of other diseases. We have a drug problem with fentanyl and other drugs that cause a high degree of mortality, particularly in younger people. So there are a lot of public health challenges that we need to address better than we are currently doing.
So I think this episode has really illustrated the value of organizations like the NIH, other government-funded organizations. How would you communicate that value of government-funded organizations such as the NIH, the CDC, to the general public who's skeptical, who, they may hear you for about a minute or two, a soundbite on TV, but they may not listen to an interview like this for an hour. But like, how would you communicate in short the value of the NIH, the CDC in addressing so many of these public health threats?
Yeah. Well, I think you just have to look at the track record. If you look at the basic and clinical research that's been funded by the NIH and look at what the payback of benefit that you have in the development of drugs for cancer that's life saving, the development of vaccines that have been life saving, the development of any of a variety of interventions that have saved so many, many millions of lives. I mean, that speaks for itself. You don't have to try and convince somebody. And the same thing with the CDC, which are the disease detectives that are out there trying to make sure that we're safe from the emergence of a number of diseases that could threaten the health not only of individuals, but of entire regions of the world. So I think the track record of those agencies speak very forcefully for themselves.
So my last question, a more personal question. You've outlined a lot of scary things. You've outlined your nightmares, your big nightmare, your persistent nightmares. How do you not have anxiety about all of this stuff? Or even if you have anxiety, how do you deal with that when doing so much of this work, particularly when we're dealing with crises that can blow out of proportion, and certainly, a massive crisis in the early 2020s that did blow out of proportion?
Yeah. Well, the counter to anxiety is the effort you put into essentially countering the source of the anxiety. So I'm a physician, I'm a scientist. I ran a major institution for close to 40 years. We dealt with a lot of scary stuff. The reason you don't get intimidated by the scariness of what you're dealing with is the work that you're doing to essentially counter that. That is a very, very powerful antidote against the anxiety, is do something about it.
spoken like a true doctor. Dr. Anthony Fauci, thank you so much for joining me here for the course of an hour. I really appreciate it. I really appreciate your service to this country. My friends are going to think I'm a little cool for being able to talk to you for an hour, but thank you so much. For our audience, if you have other questions for Dr. Fauci, his book, On Call, dives very deeply and very candidly into many of these questions I may not have been able to ask Dr. Fauci. Please go get it. Please go read it. But Dr. Fauci, for now, thank you so much.
My pleasure. Thank you for having me. I appreciate it.